Who is Surestep? Surestep is a full-service provider of custom-fit pediatric devices. Although we're best known for our revolutionary SMO, we put the same quality into our AFOs, knee braces, back braces, and more. But that's just what we do. Who we are is best summed up by the parents of our kids that we help every day.
She's very confident. She likes to have them on. It's not a problem to put them on her. And she just is confident. She's able to take multiple steps. When she falls down, she wants to stand right back up. She had a little bit of kind of turning inward with her feet, and that's completely not there in the SMOs, which also gives her more stability and confidence with her walking.
What makes Surestep unique? It's not just our heart for kids that separates us in the industry. We also offer central fabrication, exceptionally fast turnaround times within 2 days by measurement, 4 days by cast, and product innovations including Surestep trim lines, our compression method, and uncommonly flexible plastic. Thank you for attending this course. Your speaker today will be Steve Coolify.
Hello everybody and welcome. My name is Steve Coolify and I'm a certified orthotist prosthetist and educator with Surestep, and I'm going to spend the next hour discussing the innovative Surestep SMO. I'm confident this next hour will expand your knowledge of our SMO and bring a new tool to your repertoire of bracing options which can create life-changing results for your patients. Since Surestep was established in 2000, we started with one customer, which has expanded to over 2,300 customers in the United States and distribution and customers in 33 plus countries abroad. This is our headquarters in South Bend, Indiana, which houses our South Bend Midwest Orthotic Services office, Surestep, as well as our central fabrication. Our central fabrication facility, shown here, employs over 40 technicians and enables us to create industry-leading products with a turnaround time unmatched in the profession. Our custom Surestep products made to measurements are fabricated with a 2-day turnaround time in-house. To speed our fabrication, we use CAD/CAM technology to turn measurements into a 3D model, and we then send that three-dimensional image to our 7-axis robot for carving. This is one of the 3 robots of this type in the United States. It enables us the ability to carve a model in 8 minutes, which is 1/5 of the time it takes for most carvers to perform the same action. To be an industry leader, it is important to document results and compare them to the norm or standard. We use the Xeno Walkway and Protokinetic software to document and record the gait of many of our patients to ensure the best possible results for our patients. This also gives us the opportunity to compare the results of our products against our competitors' products to give us the confidence to say that we are providing superior results. Our discussion in this webinar is based on the innovative Surestep SMO. And to discuss what makes us different, there's a few main concepts that sets Surestep apart, and it is important to get these points across to understand what makes the Surestep SMO such a unique and innovative product. To fully understand the Surestep differences, there's a few key concepts that we need to discuss. So let's start with the basics. First, muscle tone. Muscle tone is how relaxed a muscle gets when it does relax. It is the measure of a resistance to a passive stretch. Essentially, there's a neurological impulse from the brain that tells the muscles to stay relatively tight or relatively loose when at rest. It is an intrinsic property of the nervous system, and we cannot increase or decrease tone, though we can increase the strength of a muscle. The green area on this image is the normal range of tone, which many of us fall into. There are also those of us that fall into the lower and higher end of normal. The majority of the patients that we treat tend to fall in the very high end or the very low end of the spectrum. What we'll focus on today and for this discussion is those children who fall into the low end of the spectrum. In reality, hypotonia, though it does carry a diagnosis code, is not the primary diagnosis in most cases. Most of the children that have this underlying low muscle tone are probably affected in other ways. Cohn and Lisi discovered over 600 genetic disorders that all brought with them low muscle tone, and I believe this has increased since they published their work in 2011. The hypotonia or low tone population is growing with leaps and bounds. There's no real research on why the hypotonic population is getting larger. When you evaluate these children at a young age, we tend to realize excessive joint mobility, decreased deep tendon reflexes, gross motor skill delay, as well as difficulty with coordination and balance. Even more importantly than the delays is the quality of movements, as their gait patterns become very compensatory in nature. Parker and Bronx in 1980 said we need to acknowledge that low muscle tone contributes to joint hypermobility. It is somewhat indirectly contributing to it. The muscles are secondary joint stabilizers, and a low tone brings a ligament laxity or looseness, which adds to the hypermobility. These ligaments are our primary joint stabilizers, and when they are lax, coupled with low muscle tone, the muscles will not pick up the slack to provide good secondary stability. This is our call to action, as we can provide devices to act as an external ligamentous support while still allowing for natural motion. We can take the place of these ligaments. In the world of physical therapy, there's a number of scales and tests to determine the excessive joint range of motion. Most of the kids we treat will score off the charts for these tests. These are kids with severe excessive hypermobility as a result of hypotonicity and laxity in the ligaments. While the scales work for measurements, and the Baton scale being the most common that we use, most of these indexes do not range high enough to score the kiddos we treat. Let's talk a little bit about tone and strength and some of the common misconceptions. First, strength is the ability to exert force on physical objects. Tone is a measurement of passive resistance. Strength is the opposite, as it is an active measurement of how much force we can generate when we activate that muscle. Strength can be increased through exercise, and tone cannot. Strength can be measured, and tone cannot. Some of the common misconceptions we see among parents is my child has low muscle tone, so he is weak. Any of the caregivers out there that have ever cast a patient with low tone has probably realized that when they want to, they can recruit an incredible amount of strength and make it very difficult for us to cast. On the other end of the scale, my child has a high muscle tone, so he is strong. Again, it's often this high tone that's actually masking the underlying weakness. What is important to realize is that kids with hypotonia are not necessarily weak. Because of the low tone, they appear to be weak. In reality, children with hypotonia don't have weaker muscles, they have muscles with less tone. When they go into closed chain, they go into such poor biomechanical alignment that they cannot recruit or access the strength that they actually have. If we can give them better closed chain alignment, we can give them the ability to access that strength and reduce the time of recruitment. When we talk about lax ligaments, the culprit is generally the deltoid ligament complex. The primary function of the deltoid ligaments is to stabilize the hindfoot and prevent excessive calcaneal valgus. There can be an argument that in the post-tibial tendon ligament and sprig ligament can contribute, but once the deltoid ligaments don't do their job and stabilize the calcaneal alignment, we end up in a severely pronated position. When we look at this foot, we realize that it's a severely pronated foot. The problem with it is that we generally want to push up on the arch and make the foot look right. The reality is the pronation is more than this. It's more than a one-dimensional deformity. It is, in fact, a triplanar deformity. What we have here is not a problem with the arch. The problem stems back to the calcaneus. If we could bring the calcaneus back to a vertical position, you would see the arch also come back into place. This is an issue with translation of the weight line. And as the calcaneus moves into valgus, the body weight continues to stretch the ligaments and drive the calcaneus into further valgus. As it goes into valgus, you get a dramatic change in the weight line, which changes everything that happens distally beyond that point. As the foot pronates, the medial longitudinal arch elongates and forces the foot into abduction. It is imperative that we remember that pronation is in fact a triplanar deformity. We would state that pronation is more than just a lower extremity issue. It is in fact a much larger issue. We would state it's more of a global issue for the hypotonic population. It's a global issue that affects every aspect of how they develop their upright gross motor skills. The quality of these skills will be affected by the severely pronated foot. Here, as we look at the pronated foot at ambulation, we can see that the valgus position continues to stay constant through all phases of gait. Over time, this will lead to contractures of the perineals and the heel cord. As we watch this gait pattern, notice that even during the swing phase, he never pulls out of pronation at any time during the gait cycle. Here we see a 2.5-year-old that is walking for 6 months. Here, with 6 months walking experience, we see no improvements whatsoever in her gait pattern. We still see a very wide base, a very high guard, and a very clumsy gait pattern where it's almost like with each step she's struggling to stay upright. It is also very important that we consider ossification and bony development. On the left, we see an adult foot fully ossified. On the right, we see a toddler foot. Notice that the medial column is much more cartilage and not yet ossified. So an important question: can we affect ossification and bony development? Touching quickly on bony development, ossification starts in utero. Wolff's law states that bone will develop based on the loads that's placed on it. If load is increased, bone will become stronger. If load is decreased, bones will become weaker. This has been evident with some of the studies of our astronauts coming down from space when they start to have osteoporotic symptoms from not being under gravity's load for over a year's time. Only cyclic loading can induce bone formation. So question, once again, can we affect bony development? Here we see a really extreme example of how we can affect bony development. This is the results of foot binding, which generally starts around 3 years of age and changes the shape and the size of the foot. In 1997, the University of California, San Francisco, did a study and found that patients that had gone through these bony changes were less able to squat, they were more likely to have fallen, they had very poor balance, and we found 5.1% lower hip bone density as well as 4.7% lower spine bone density. So by binding the feet and changing the development and the bony structure of the foot, it did in fact make changes all the way up the chain. What's very important for us to realize, again, when we consider some of these patients diagnosed with hypotonia, that during ambulation and the cyclic loading and ossification and bone formation, early intervention is the key. If we can get them into a better position and better alignment, we can help them ossify in a more typical position. When we look at the posterior view of the calcaneus in the typical developing foot, on the left, we see good vertical alignment and an upward sloping sustentaculum tali. On the right, with more valgus position calcaneus, we see a downward sloping sustentaculum tali. Looking at the circles below, we see that the talar head is very well supported on the typical developing lower extremity on the left, but we see on the right that almost 50% is unsupported with a downward sloping sustentaculum tali. So if we consider adding the body weight coming down through this alignment or malalignment and couple it with ligament laxity found in hypotonia, we end up with a severe pronated foot throughout the gait pattern. So now that we touched lightly on ossification, I think this slide really adequately depicts something very important. If we look at the change in the body structure from newborn to adult, significant changes happen as we transition, but never more than the first 2 years. In the first 2 years, more changes happen to our bodies than ever again in our lives. Weight will quadruple, height will double, and head circumference will increase in 1/3. As we consider that ossification is occurring in the lower extremity all the way up to 7-8 years of age, and the significant changes that happen in the first few years of life, we firmly believe that early intervention is key to correcting any alignment issues, providing support for ligament laxity, and helping to ensure that ossification is happening in proper alignment. Again, early intervention is key when we see these issues. Normally, to address a pronated foot, we would consider a few bracing options. There are 3 main devices that come to mind and that we've utilized in our field for decades. Traditionally, foot orthotics, UCBLs or University of California Berkeley Laboratory, and traditional SMOs or supramalleolar orthoses have been used to try to stabilize the foot and try to gain a subtalar neutral calcaneal alignment. Ultimately, we're going to alter the pronated foot and bring it into a good position. We've been taught that the subtalar neutral position is the preferred position, but the challenge is that this is a static position. To hold the foot in a static position is not optimum, as the foot is dynamic. Through static alignment and through this methodology, and it may have a place in orthotic bracing world, we do not believe that static or rigid products have a place on the children we treat with hypotonia. In the case of foot orthotics, we are undermanaging. In the case of traditional UCBLs or SMOs, we are overmanaging by using these rigid devices. In all 3 cases, we're taking away their ability to develop a natural or normal gait pattern. Surestep manages this very differently. First and foremost, we do utilize an SMO designed brace. But this is not in any way a traditional SMO. This is a unique device that has been designed using a very different approach. It is different in appearance, it's different in function, and it is different in concept. The first thing you'll notice is the braces look like they were made for the wrong foot. We generally see trim lines where the longer trim line is on the medial side of the foot and the shorter on the lateral. The Surestep SMO does it differently. We bring the trim lines back on the medial side of the foot proximal to the first metatarsal to allow adduction of the forefoot and allow for movement and development of the windlass mechanism, as well as provide a long lateral trim line distal to the 5th metatarsal to help adduct the forefoot. Remember, when looking at the display of the triplanar pronation, as the foot pronates, the forefoot abducts, and we need to adduct that forefoot to help provide better alignment and support the foot triplanarly. The next thing you'll notice is an incredibly dynamic and flexible poly. This is no way a plastic this soft can possibly support the foot. But in reality, we do not want to support the foot, as that is a static purpose. What we are here to do is create a midline stability so that the foot can move in and out of midline in the same dynamic motion that the foot was designed to do. Our goal is to create an external ligament support that will allow the natural motion of the foot in its dynamic nature so that the foot can move intrinsically and much more normally. This incredibly flexible poly allows us to squeeze the foot and create hydrostatic pressure, which improves better alignment and better stability without having to lock the foot into a static position. We all know the concept of hydrostatic pressure, but an analogy that we like to use is that of a plastic water bottle. What you'll notice is that the bottle has the ability to flex and move only in a small range. The water in the bottle will not allow it to move excessively. Imagine, with no water in this water bottle, how easy it is to crush and how thin that plastic actually is. This is very similar to using polymer on the foot for alignment, position, and stability. We can use an incredibly thin polymer and dynamic polymer, as the foot in itself is ligaments, bone, and water. And providing this support, we do not need to use the rigid polymers that we've used in the past to try and get that alignment, but through compression and stability, we can actually provide better alignment with a much more flexible and dynamic polymer. The shape of the device along with the hydrostatic pressure creates a synergy where the bottle can be plantar flexed or dorsiflexed or supinated or pronated, but not excessively. So the question is this: what if we can do this for the foot? What if we can take the foot and create stability while still allowing it to move through its natural motion throughout the gait cycle? And that is what Surestep has created. The advantage here is dramatic. First and foremost, these children have the ability to build their intrinsic muscles in a much more natural and normal way. Look at the dynamic responses and the balance reactions actually happening right through the SMO. When using rigid braces, these balance reactions cannot in any way transfer that movement down to the floor to help create stability. But with the Surestep SMO, we do keep this dynamic motion, and we can transmit that input down to the ground and provide better stability. Additionally, with this intrinsic movement, the joint receptors begin to function again. And once we get them into the SMOs and increase compression, we're really creating an exoskeleton deltoid ligament complex, and we're able to do the job of the ligaments within the foot and ankle by stabilizing the foot yet allowing for it to function more normally. When bracing with the Surestep SMOs, it is imperative that the straps be tight to ensure hydrostatic pressure, optimum support, increased somatosensory input, and improvement in alignment and function. On the left, we can see gapping from the loose straps. And then we can then see the instability in this patient has when the straps are loose. On the right, we see an improvement from the compressive nature of the Surestep SMOs. Again, it is imperative that the straps be tight for the Suresteps to function in their intended manner. Here on the left, we see the Surestep with its uncommonly flexible plastic in comparison to a more traditional SMO on the right. Notice that it's significantly more flexible with a much shorter foot plate and a much more dynamic style and flexible polymer. How this translates to our patients is that on the top left we can see a patient pulling on his pants with the Surestep SMOs, and down to the right side we see the same traditional SMOs being utilized. Notice the balance reactions and the movement on the patient wearing the Surestep SMOs. And if we watch the video down on the right section, we'll see as he pulls his pants on, he in fact falls over when trying to put them on because the balance reactions cannot transmit down through the floor with the traditional SMOs. Another thing that's very important to note, and something that baffled me for decades in the industry, was why do physicians make some of the statements that we hear on the left? Children don't develop their arches until age 6. We know that's not true. Do all toddlers pronate? It's normal to the age of 3. Let's wait and see if it interferes with gross motor development. There are no symptoms, therefore we don't need any treatment. These are a lot of common statements that we've heard lecturing across the country that have frustrated a lot of the orthotists and therapists when they've reached out to the physicians to request bracing. We had the opportunity to attend a few physician functions and listen to a number of different industry-leading orthopods, pediatric podiatrists, and other physicians speak about why they don't refer for bracing. One of the interesting things that we took from this course was the fact that the number one reason that a lot of the physicians didn't recommend bracing is that the full foot plate to the end of the toe rigid polymer designs that we've utilized in fact impacts exactly what we see here to the right. What we're looking at on the right is an image of what's known as the windlass mechanism, which in essence is a helper mechanism. If we all reach down right now and pull up on our great toe and our toes, we'll feel the foot supinate. This is meant to be a helper mechanism from a plantar aponeurosis that attaches the calcaneus to just behind the first metatarsal head and wraps underneath the metatarsal head to the toes, so as we pull up it in fact supinates the foot. In normal ambulation, as we move from second through third rocker and roll up onto our toes, this helper mechanism is meant to supinate the foot to create better propulsion for push-off. It is very important that the windlass mechanism develops, and many of the doctors stated that the rigid full foot plate braces that we've been utilizing in the past, and by locking up the motion of the first metatarsal head, were in fact doing more damage than good when it comes to development. With the Surestep SMO, we do not hinder this development. With the unique design of our trim lines and foot plate, and the fact that we don't use full foot plates on our SMOs, all of this natural development can happen in these braces and are in fact something that the physicians would approve of. So it's important to notice that along with the fit and function, natural motion remains intact with the Surestep SMOs. The things that the children can accomplish with these are nearly unlimited. They can walk, run, tiptoe, hop, transition from the floor up to standing. And how many other kids in the braces can do this? The only motion we're looking to control is to reduce the excessive movement, not the necessary movement. And all necessary movement with the Surestep SMOs remains intact. Now we've discussed distal up to now, but what happens proximally? It has much more impact. It's much more life-changing. When we go into closed chain, this dramatic change and shift in the weight line happens right up the kinetic chain. It is causing terrible positioning, resulting in poor motor function and slower and awkward development of the crow's motor skills. We're seeing some of these effects up the chain here with this young fella, coupled with a lot of bad practice These are things that we can change through proper bracing and through working hand in hand with physical therapists to break down some of these motions and some of this practice in poor positioning. We can in fact make a significant difference. Now, looking up the chain, and as the children go into severe pronation, we see the knee drawn into a dramatic valgus position. With any of us, our medial collateral ligament would support our knees and ensure that we do not go into this valgus position. With children we treat with hypotonia, the global laxity in their ligaments and the knees become more susceptible to going into valgus, and the hips then adduct, causing an immense increase in energy expenditure to compensate for this. Now, with the muscles working out of normal range and the joints operating out of normal alignment or optimal axis of movement, it reduces efficiency. Thus, the population of children tend to move through their development in a much slower and lethargic way, and it takes a great deal more energy and effort to do simple tasks than typical children. So what we tend to see are these balance and coordination issues. We tend to see a dramatic increase in the wide base of support, increased trunk movement, excessive weight shift, a high guard, also coupled with high fatigue. Pulling to stand and lateral weight shift. We really can't do much with the children's feet until they're at the point where they're pulling to stand. By this point, they're often 3, 4, maybe 5 months behind getting here when they should have. But now we have the opportunity to do something for them. Watching them pull to stand and shifting weight, we watch these children fall further and further behind their peers. We then start to see some independent standing and then the first steps. As most children develop their gait, they'll get more and more efficient. With the hypotonic children, and because of their instability, ligament laxity, poor alignment, and extra mobility, they have instability that they can't get past. As a result, they reinforce these patterns so that once the independent walking, the quality of the steps do not improve. In order to avoid building these patterns of abnormal gait and reinforcing these movements, we need to address these children when they pull to stand. When they pull to stand and we see excessive valgus, these are children that we need to treat as soon as possible. The longer we wait, the further they get behind their peers. Again, early intervention is key. So the question then being, when do we treat? Are we noticing excessive valgus? Dr. Valmassi from San Francisco established the Valmassi Foot Position Index, which states that normal pronation can be determined as 7 minus the child's age. Again, that's 7 minus the child's age. That will give us the amount of subtalar valgus that should be present. Anything more, we should consider options for treatment. Is the patient symptomatic? Are they feeling pain, discomfort? Often that's hard for us to really have communicated with some of the younger children we treat. But is there a lack of dynamic control? And by dynamic control, we mean as they're taking their steps and we can watch them walk, are they pulling from a pronated position into a supinated position during swing phase? Or do they stay pronated through the entire cycle of gait? It is important to realize that subtalar neutral is a moment in time and nothing more. We have been taught that subtalar neutral is somehow the perfect position that determines neutral alignment. The issue is that that is a static position and the foot is dynamic. By holding the foot in subtalar neutral, as we've done in the past with traditional rigid bracing, we remove all balance reactions and natural dynamic movement required by the foot and ankle to adjust to uneven terrain and provide a smooth and efficient gait pattern. It's also important to remember that neutral alignment might not actually be a functional position for the patients that we're treating. So we've talked a fair bit up to this point about the uniqueness in the methodology behind the Surestep and the uniqueness in design, and let's now take a look at how they work on some of the patients that we work with. This is Corwin. Corwin's 16-month-old, diagnosed with developmental delay, hypotonia, and pronation. He's pulling to stand right about 15 months, and before that, no independent standing or ambulation. We're seeing him here day 1 in his Surestep SMOs, walking one hand held. We're seeing improvements in balance, but still with that high guard and wide base of support. Week 2, we can see him working on his balance reactions and postural control, gaining better stability, the ability to reach on down and squat and stand back up. Here we're now at week 5. We're seeing his ability to walk on an even terrain, be able to reach down and stand back up confidently. We've seen a significant lowering of the guard, decreasing base of support. Now the ability to carry objects outside, be able to navigate external perturbations, working on stepping up and down the stair. He's starting to crawl up and down the stairs. Here he is at week 8. Postural control and stability still improving. Ability to get up and down and traverse uneven terrain. Ability to kick the ball. Here we are now at week 10. Nice lateral movements. Much more confident in the stable gait pattern. Week 14. Gait pattern still improving. Much better postural control. And by week 16, we're seeing a wonderful gait pattern and significant improvements. So what this was, Corwin was part of a study in Megan Smith's Winning the Waiting Game. Megan is our director of research, who's done a lot of research with Surestep and put together Winning the Waiting Game to see how, and see as well as document the results we get when using the Surestep SMOs. When she did her case studies, she looked at where the children were when they were starting pulling to stand and documented how delayed they were. Bottom line showing the typical and the upper line showing the rate of delay, we see these lines begin to converge. Once these children were fit in Surestep, they gained motor skills at twice the rate than without. This tells us when using the Surestep SMOs, we can dramatically improve the rate of gain. Why wouldn't we want to give every one of these children that advantage? Again, early intervention is key. So from the baseline, we can see that we're ultimately working to close the gap with the Surestep SMOs. What a wonderful thing. By gaining that stability and confidence, we have the ability to help these kiddos help close the rate of delay and work to catch up to their typical peers. In the Winning the Waiting Game, there was an average of 9 case studies. The average age of pulling to stand at just under 14 months, at about 4.9 months delayed. Cruising at a little over 15 months, or 5.3 months delayed. And they received SMOs at 15.6 months, with a range between 13 and 19 months. From that time, the rate of gain of gross motor skills of a typical 0.57, the study participants after receiving the SMOs were 0.27, which is more than twice the speed of gain. By the end of the study, walking fast at an average of 20.3 months was only 2.3 months delayed. So what we see here is a fairly typical low-tone gait pattern. We see a real wide base of support, high guard. Proprioceptive issues are fairly evident with a lack of lateral weight shifts. Overall, just a very clumsy gait pattern with each step really kind of just struggling to stay on his feet for the most part. We see reduced righting reactions and overall kind of an abnormal stability and abnormal movement patterns. So here he is starting off in his day 1 in his Surestep SMOs. As we can tell by looking at his shoes, they were numerous sizes too big. Now we can see him in much better shoes. we right away start to notice a little narrowing of the base of support. That high guard, the arms have dropped already, and again, that was day 1, so he really recognized the increase in stability with the SMOs right out of the gates. Here we are at week 4, we're starting to see a much smoother gait pattern, much better balance and righting reactions, better postural control overall. Ability to kick the ball. And we look to the left where we see kind of a barefoot, and then to the right we saw him in the SMOs, and here day 1 and week 2. So a significant difference and a significant improvement in a very, very short time than the Surestep SMOs. So let's take a look here at Camden, now 3 years old, been wearing SMOs for 6 months. We get a chance to watch him ambulate barefoot at first. It's a fairly decent heel-toe gait pattern, but not a lot of kind of reciprocal arm motion. Here he is now in just his shoes. Now in his SMOs. And we can start to see a little better leg and arm disassociation. More fluid, smooth gait pattern from 6 months. A little more pelvic rotation, definitely better stability overall, and better postural control. And a much more fluid heel-toe gait pattern. So doing a comparison side by side from day 1 to month 6, we can see much more relaxed arms 6 months later, and we see much better swing and pelvic rotation. Let's watch in slow motion for a couple steps as we see the difference from side to side. Now comparing barefoot right single limb stance, we can see much better stability. Now looking at right single limb stance in the SMOs and shoes, we see significantly better postural stability, reduced upper arm swing for compensation, and ultimately we're able to provide stability with mobility through the SMOs, creating better balance reactions, single limb stance, as well as overall improved postural control. In comparing on day 1 alone, he was able to stand on the left foot 235% longer with the SMO than barefoot. That's 2.2 seconds versus 7.5 seconds. Was able to stand on the right foot 66% longer with the SMO than barefoot, which is 4.9 seconds compared to 8.1 seconds. The mean center of pressure and velocity decreased bilaterally. And upon evaluation of his gait pattern, his step length had increased, as well as his velocity had increased. In year 2 follow-up, we see significant improvements in balance reactions and single limb stance. He's now able to stand on one foot, similar to what we would expect for someone in Ethan's age group. Looking at a year 2 follow-up in the SMOs are still improving his stance and balance, but again, significant gains were made over 2 years' time with the implementation of Surestep SMOs combined with physical therapy and gait training. An independent peer-reviewed study done by Dr. Kathy Martin at the Cranert School of Physical Therapy in 2004, she did a study on 17 children diagnosed with Down syndrome over 10 weeks and showed that they had a statistically significant rate of change over a typical child wearing their Suresteps. These children did not have as significant of a change as those that were displayed in our Winning the Waiting game, and we attribute that to their age. Even though there was notable improvements, these kiddos were 3.5 to 8 years old, which means they had much more time to develop their poor habits and they have dealt with these deficits for quite some time. Thus again, we strongly believe that early intervention is key to success. Taking a quick look at a very short style UCBL cup and foot orthotics as compared to the Surestep SMOs, we see much better support and alignment in the Surestep SMOs. Once again, it's important to remember that a triplanar deformity requires triplanar control to gain the stability, support, and alignment that we need. Here we see a young gentleman barefoot with compromised stability and balance reactions, and he has a hard time standing without bracing support. The original SMOs that he received offered very little support and were fairly rigid, and he had challenges trying to get his balance reactions to work through his SMOs. We can see the toe grasp reflex happening as he tries to gain stability through his toes. So it's important to understand that not all SMOs are created the same. Here in the Surestep SMOs, we see much better stability and alignment. He's no longer needing to grasp with his toes. We see better balance reactions right through the braces transmitting down to the floor with the dynamic Surestep SMO. The Surestep SMOs are a patented device with unique dynamic polymer that cannot be copied or fabricated by a local O&P provider or competitor. If it's not a Surestep SMO, it will not function like a Surestep SMO. So what are the weight limitations on the SMOs? Generally, the Surestep SMO is effective on patients up to 80 pounds. Knowing that we would be required to treat patients with higher body weights, Surestep answered that by creating the Big Shot SMO. We make both the Big Shot Light and the standard Big Shot SMO. The Big Shot Light is a great choice for those patients from 50 to 90 pounds that may have significant bony prominences or higher activity levels. The Big Shot SMO is recommended for patients 80 plus pounds. If we take a look to the right, we can see that the Big Shot SMO has the same incredibly flexible and dynamic properties as the normal Surestep SMO. And how we've done this is by creating different cutouts and pockets and using an inner liner to maintain that same dynamic ability, once again enforcing Surestep creates stability with mobility. Here we have Logan. Logan is 5 years old. We can see upon stance, we can see significantly pronated posture. You can see genuvalgum at the knees with his knees touching each other. Logan was originally seen because of his significant pronation and general clumsiness. Here we can see Logan running and jumping. And notice that when he's running and jumping, we have that lack of dynamic response. Logan stays completely pronated through all phases of gait. Looking at single limb stance, we can really see a significant amount of calcaneal valgus and overall pronation. And Logan was prescribed by his physician foot orthotics. The challenge with foot orthotics, again, is a triplanar deformity requires triplanar support, and Logan pronated right over the top of his foot orthotics. Logan's parents were quite frustrated with the poor results and came to us for a better solution. With the Big Shot SMOs, Logan had excellent results. He had significantly better alignment and positioning, much better stability, and Logan was very receptive of his Big Shot SMOs. His alignment and support were excellent, and his parents were very pleased with the support and compliance, as Logan really liked the SMOs and continued to use them not only for ambulation, but for all his athletic activities. So looking at gait mapping in the Big Shot SMOs, we see some great results. The step lengths were longer in the Big Shot SMOs, were faster in the SMOs, and the center of pressure line was smoother and followed more typical pattern of pronation and supination with the Big Shot SMOs. So let's hear a parent attestation comparing her experience with traditional SMOs and the Surestep SMOs. This is a great attestation that also compared side by side more traditional bracing with the results that we get with the Surestep SMOs.
So with Zach, who was the smaller one, the 15-month-old, I noticed he was turning his foot more out to the side. And it was heavier. He almost walked like with clogged feet, like his weights were on his feet. With Cameron, who is 2.5, he was stubbing his toes and had a harder time walking in the other braces compared to the SMOs. And he was not able to jump. And the other ones, compared to the SMOs, he's able to jump. And he couldn't do that. My comment was, how are you supposed to jump in these? They're really hard. They were harder to put on. There wasn't much give to them. And they looked very uncomfortable. And I just don't know how they would actually, the boys would have liked those, because they didn't like them really being put on at all. They had a fussy fit with them. I also think the way that it comes to the bottom, he can use his toes to walk. He likes to use his toes to walk anyways, but in the other ones, it goes all the way past his toes, so he can't use his toes for his gripping. And especially when you want to jump, you jump on your toes, and I don't think he could get the flexibility he wanted to be able to jump in them. With Zach, without the SMOs at home, if he doesn't have them on, he's falling all over the place. He will be running around and just face plant. So the SMOs really help him with his balance and his walking. Same with Cameron. But I know for sure that if they don't have them on, they have issues. They have major issues walking. They're falling, and they need them. So they've helped us out a lot, because without them, they wouldn't be walking.
A common clinical question we get is, when are we done with SMOs or an SMO treatment plan? We feel there's a few key elements to consider before we consider transitioning out of SMOs. I personally believe that there's often social factors that help compel us to remove our children from an SMO treatment plan sometimes earlier than we should. So first, are we seeing better calcaneal valgus or calcaneal alignment? Are we seeing the foot structure in a more typical position? If the patients were originally treated because of pain or fatigue, have we now seen a reduction in those symptoms? Are we seeing better coordination and balance? If they're originally fit due to a developmental delay, have they now closed the gap somewhat and caught up to their peers? The one that I think is most important to also consider is dynamic stability. Have we improved in dynamic stability? When we say dynamic stability, again, we don't mean just alignment, balance reactions, or postural control. We mean, is the foot properly supinating and pronating during the natural phases of gait? Though many of the patients we initially treat might be significantly pronated, we don't expect to see perfect alignment and complete fixing of that alignment, but we do expect to see a better pronated and supinated foot in the proper phases of gait. It's also important to consider that transitioning into a UCBL or foot orthotic is preferred over transitioning into nothing. One other option in our Surestep line of SMOs is our toe walking SMO. It is, in essence, a Surestep SMO with a posterior extension. This posterior extension acts as a kinesthetic reminder to bring the heel down to the floor while still maintaining the same great dynamic responses that we see with the Surestep SMOs. They are trimmed behind the metatarsal head, similar to that of a Surestep SMO, and they can then be trimmed down to that of a Surestep SMO once we no longer need the high posterior wall to act as a kinesthetic reminder. We generally use the toe walking SMO for mild toe walking due to excessive pronation, sensory deficits, as well as habit. And the great thing about this option of SMOs is we no longer need to use the tall AFOs with a posterior stop, which in essence reduces a lot of the natural motion and third rocker that is required for many of the activities that children perform. There are times that a full AFO is still required, but the toe walking SMO is a great option for those children that fall under the more mild deficits. How about different resources for SMOs? Megan Smith developed a spectacular article called Surestep SMOs, an optimal solution for pediatric flexible flat foot. It is an excellent resource for mom and dad, the therapist, physician, etc. We can provide this information to you through email, and gladly reach out to us, contact us, and we'll gladly send it along. As a wrap-up, the Surestep SMOs and stability with mobility. They're very unique in that they provide stability in and out of midline. They allow the child to build a repertoire of movement patterns and increase variability. And we provide a tool to learn, not something to rely on. We use circumferential compression to improve somatosensory input, improve lower extremity alignment, improve the weight lines and the ability to laterally weight shift. And it's important to consider a consistent wear time for consistent practice. We firmly believe the Surestep SMOs are the best option in the industry for the patients you treat. We thank you for joining us today on the Surestep Academy for our online, on-demand, and in-person educational options. We hope you've enjoyed the discussion on the Surestep SMO, and for any questions, comments, or more information on any of our SMOs or any of our line, feel free to contact me at stevek@surestep.net. We thank you for joining us today and hope you'll find the time to look through some of our other educational offerings or join us at one of our in-person presentations coming to an area near you. Thank you.